Well, I'd like to welcome everyone, both in the Davis Center and people who are online, to our VCBH lecture series for April. I'm Philip Adis. I'm the Associate Director of the VCBH, of which Steve Higgins is the Director. And today we're very fortunate to have as our speaker, Dr. Paul O. who's Medical Director, Endowed Chair in Cardiac Disease Prevention and Rehabilitation at the University Health Network at the Toronto Rehab Cardiac Center. Paul is also an Associate Professor of Medicine at the University of Toronto. I would add that the Toronto Cardiac Rehab Program is almost certainly the largest program in the world. They see over 2,000 new patients annually with a long history of groundbreaking research. Paul obtained his MD from the University of Toronto in 1988 and completed specialty training in internal medicine, clinical pharmacology, and clinical epidemiology. He's participated in many national guideline committees, both in Canada and in the US, and has held leadership roles in several provincial and national advisory committees around heart health and policies. He has over 300 peer-reviewed publications and is principal investigator on a number of grants examining exercise, uses of technology, behavioral and educational interventions for the primary and secondary prevention and management of cardiovascular conditions, diabetes, and other chronic diseases. In the last 5 years alone, he's received over $10 million, unfortunately in Canadian dollars.
But two US.
Nonetheless, a lot of money, in research as being an international leader in the development in the cardiac rehabilitation setting, where for decades we've exposed cardiac patients to behavioral and educational interventions, not knowing their efficacy. Truly an honor to introduce Paul O. as our VCBH for the speaker for the month of April. And the title of his talk is Health Literacy and Cardiovascular Rehabilitation, Bridging Gaps for Better Health Outcomes. Paul.
Great. Thanks very much, Phil. We won't get getting some echo. Hello to folks online and in the room. It's a real pleasure and privilege to have ventured south of the border to this beautiful state, the Green Mountain State, I believe, as is termed. Actually, I'll share my first anecdote with you that we do have actually a connection to Vermont, that my son was recently married to a lovely person who hails from Vermont. She went to Champlain College. She worked at the Vermont Teddy Bear Company. Is there anything more Vermont than that? Can I say that she can speak about maple syrup at length? So we actually do feel a close connection to Vermont. And I'm delighted. I was sending photos of downtown Burlington and Church Street to them last night. I said, here's Ben and Jerry's. Am I in the right place? And they indicated, yes, you are in the center of the universe. So I'm delighted to be here also at this Vermont Center on Behavior and Health that I've had wonderful conversations last night and this morning, learning about the fabulous work that's ongoing. And what I said to Steve earlier was, I wish I had been here 10 years ago so that we could have actually figured out things that we could have worked on in the interim, but many things to come. Let me share some disclosures with you before I move too far, that I do serve on a couple of advisory boards around cardiovascular therapies for a couple of companies, that I do hold research funding from a number of agencies, peer-reviewed agencies in Canada. I have a chair that's supported through our hospital foundation from an organization called Good Life Fitness. And I do have some research funding from Apple as well for some of our technology and cardiac rehab work. But we're talking education today. I'm going to try to advance my slide. There we go. A little bit of the setting, and Phil has already alluded to where we come from. So I'm north of the border, just a little bit north of the border in Toronto. These are some images from our actual cardiac rehab location. This is the program that was founded by Dr. Terry Kavanagh in 1968. It's gone through a series of physical developments since then, as well as many programmatic evolutions. But you can see we have a lovely footprint where we have the ability to see at least a couple thousand people per year, structured programs that include exercise and nutrition and cardiovascular health management, and importantly, behavioral interventions as well, along with an education and research platform on top of that. And today we're focusing on one aspect of that, but I'd be happy to engage at any time on anything else that might be of interest. We've been running on-site programs for like over 50 years. In the time of COVID, we moved from a small virtual program to a very big virtual program and have landed on hybrids, much as we are in this current environment right now. One of the neat things about Toronto that you may be aware of is it's one of the most diverse places in the world. Large communities of people from all over the world. There's over 100 different languages that are spoken in Toronto, and there's variation in socioeconomic gradients across the city as well, which makes it a fascinating, exciting place to offer clinical care, to do research, and also just to gain insights into the world. But you could also understand that there'd be a number of challenges that might come up in this way. And that's part of the inspiration for some of the work that we're going to talk about now around the patient education platforms and health literacy. So about 15 years ago, we decided to focus in on this area alongside many of the other research platforms that we have around exercise, behavior interventions, epidemiology, but health education or patient education was one place that we want to focus. And so for the purpose of this talk, we want to go through defining health literacy, why that might be really important, and what's the relationship between health literacy and health outcomes, describe what the setting is in the United States in this, come to at least 5 different strategies that you might implement in the programs, the research that you're engaged in, and share some resources around this, what I think is an important domain. And I'm grateful to Phil and Patrick Savage from the Cardiac Rehab program. We've had conversations around this theme before at various national meetings, and they were kind enough to develop this invitation to come. In a different setting, I would have actually shown you this live video, but I'll leave it to you as something that's a takeaway. So why is health literacy an issue? And this segment called Health in the City, that was done by a couple of fun sort of social media bloggers, went onto the streets of New York. And okay, it's okay to beat up on New York. Is that okay? Yeah. So on the streets of New York, you'll meet interesting characters, including Spider-Man, somewhere around Times Square. And a couple of fun things that they did was, ask New Yorkers, what do you think hypertension is? And you could predict what the responses would be. Hyper means, moving too much. Tense means you're too tense. So it's people that move around that are tense. Angina was likened to female body parts. When people were asked seriously, what is your interaction with your healthcare provider? Many people, quite honestly said it's quite challenging. I never have enough time. They don't listen. They don't tell me things that in ways that I might understand. And it just set up the notion that health literacy is a challenge. It's critically important to the dynamic. It's critically important to health, but there's something wrong with this equation. And the literature and other kinds of supporting research would support that. So if we look to a definition just to ground us, that health literacy is the ability to access, understand, evaluate, and communicate information in a way to promote, maintain, and improve health over the life course. So it's not simply that I know what I read. There's a whole kind of digestion and enabling and action that happens through the health literacy experiment. Health literacy and health outcomes are closely tied. And a whole host of literature would suggest that limited literacy skills are in fact one of the strongest predictors of poor health outcomes. In all of our own domains, we may focus in and feel the thing that we are doing is most important. If I put on my hat as a pharmacologist, or if I'm with cardiologists in the audience, then it's like the procedures that we do or the drugs that we give. is ultimately the most important thing, right? If I'm with behavioral people, it's the actions, the self-management skills that I might have. If I'm with smoking researchers like Andrew Pipe on my side of the border, smoking is the most important thing that we can, smoke cessation is the most important thing. So everyone has their own thing. But I will argue that this is the fundamental thing. If you don't know about yourself and the things that impact on your health, then bad things are going to happen. Like people with low literacy are less likely to understand their disease and symptoms. It's not surprising when I meet people 6 weeks or 6 months after their bypass operation that don't understand why their chest has been split open. What happened? And that's the time when we have the conversation. They're less likely to know how to monitor and manage their condition. They have greater difficulty using devices. They're pervasive today. Everyone invents a new device or an app, and this is the secret to better health management. Well, most people don't know how to use them. Thank you very much. But we'll go on inventing. They make more errors taking medications. Of course, we're all aware that like 1 out of 7 people today in this hospital are here because of a medication error. Either something that I would have done as a physician, or somewhere along the transaction of medications being taken, consumed by people rightly or often wrongly. People with limited literacy often miss appointments and tests, and they receive fewer preventative services. They may be labeled as a difficult patient because they don't show up. We went through all this trouble to book you for your x-ray. You never came. Why are you so difficult? And if the answer is, I don't understand the calendar in my phone and how to access it, or I've got limited numeracy skills and I can't figure out what 17,493 means or 23 means. So these sorts of things. I've got a mouse that's going wild. Why is that? They use the inpatient emergency departments more often, and they cost the healthcare system much more. In the area of heart disease, if we actually look through the literature, and our group did this and published on it a few years ago, that there was this similar kind of finding that if one actually measures health literacy and looks at heart disease outcomes, independent of everything else, we look at LV function, how many arrhythmias that you have, and how many coronary vessels are blocked. But independent of all of that stuff, if you have low literacy, you end up coming back to hospital. You have more anxiety, you have lower social support, lower health-related quality of life. But we never talk about this in medicine as a fundamental thing. We focus on, did you take your antiplatelet drugs? Are you on your cholesterol medications? Did you stop smoking? Which are all really important, but this is something else, kind of as a newer sort of domain. So when people take this stuff back to home, our great advice, these are the conversations that may percolate in people's heads, like from the cardiac rehabilitation programs that I work in and that many of you might work in. We very smartly match people up with brilliant and talented case managers who say, I'm going to give you an individualized exercise prescription. I would like you to walk a certain duration, certain frequency per week. I'd like you to lift some weights. I've even developed a good nomenclature, short forms, so that we can be very efficient with our communication. And the person will nod, yes, yes, I understand. And then at home, they will say something like, I don't feel so smart about this. I can't remember. What is an HR anyways? What do BPMs mean for my beats per minute of my heart rate? A pre and a post, like one's before, one's after, but I don't quite know which one. RPE, a rating of perceived exertion on some crazy scale that goes from 6 to 20. Go figure that out. RT is resistance training, EX for exercise. Man, someone who's living with diabetes in the lower left who was given a glucometer, great. I'm giving you this medical device. I'm empowering you. You can check your sugars as many times you want through the day. They look at the numbers and say 70 milligrams per deciliter, which somebody would have said, that's great. You're right in the range. Excellent control. And this person is on insulin or sulfonylureas, like something that can make your sugar go low. They say, I'm ready for exercise. I'm ready to go. My sugar is perfect. Of course, some folks in the audience would recognize this is a recipe for disaster, because once this person starts exercising, their sugar goes from 70 to 60 to 50 to 40, and they land in the emergency department, which is a known effect of exercise. That's excellent. But if you aren't ready for it, then this is a bad thing that's going to happen. And this is part of the literacy thing. It's not just giving a device, but it's understanding what those numbers mean and what actions one needs to take. Upper right, you're given drugs, and we give evidence-based medicines like aspirin and clopidogrel or ticagrelor. These are the things that will keep you alive. But the other information sources that people receive, and we've heard these things in the last couple of years, right? Drug X for blood pressure or something else, it's contaminated, it'll cause cancer. Sound familiar? Stomach pills, heart pills, all these things come up, and they say, I'm going to stop these pills, not recognizing that when you stop the pill, things like your coronary stent are going to thrombose for the right or the no, obviously for the wrong reason. So these things happen, and someone that goes to the drugstore and gets the insert, the very long, everyone got one of these, the accordion insert from the drug package or the multi-page printout that will list every side effect known to man on it, including death. Like every pill will cause death. Why is that? In every randomized trial, somebody died, not because of the drug, just because something happened. They got hit by a bus, lightning struck them, whatever. But the person will interpret that as saying, this drug that you gave me is going to cause me to die. I'm not going to take that, right? So these are the real life challenges of literacy. Only about 12% of the US population would be deemed to have proficient health literacy. Maybe 50% have sufficient health literacy. A smaller number even have proficient numeracy. We're going to go through some exercises in a moment. But this is a big issue, right? So this is why it's worth spending a bit of time about this, because it is so common in the population. And we give this as a transaction every day. Here's an AMA video, one more for you to watch, but in it, it describes the challenges that people face. I don't understand the prescription label. How many milligrams am I supposed to take of this pill, et cetera. And about a third of US adults would have difficulty following the thing that's on the pill bottle. That is the only instruction that's there. It's meant to be so brilliantly clear. Take one pill 4 times a day. What does that mean? Because we, as physicians, we go through secret medical training, right? To write illegible prescriptions in short form with a little bit of Latin in it, so that we scribble something, 1 cap QID, and then expect people will understand what that means. Back at home, the person might have understood I should take things 4 times a day. They'll start the first one at 6 a.m. And then what? Then what? Is it like every meal I'm supposed to take then? Is it lunch and dinner and then bedtime? Or is it every 4 hours while I'm awake? Or is it really every 6 hours and I have to wake myself up to take the dose that's going to happen while I'm sleeping? So we create these kinds of confusions, and bad things happen not only clinically, but bad things happen financially. So for each person who's living with low health literacy, analyses have suggested there is an incremental cost to this as well. Hundreds or thousands of dollars of extra healthcare costs that are associated with limited health literacy. And you sum that up, $73 billion a year. If we gave Dr. Higgins $73 billion, we could do lots of really great things for the state of Vermont and the country as a whole in terms of behavioral interventions. So we should do some different things. And so here's 5 things that we might think about. Whether it's research materials that we're going to give out tomorrow, clinical things that we might do, or just encounters at home. Just think about this. Bridging the gap, that there is a lot of things that we can do in user-centered design. We'll talk about that. Using plain language and clear design, assessing for health literacy, checking for understanding, and a new version of universal precautions that we're going to go through in a moment. So user-centered design, we had a bit of a chat about this at the Cardiac Rehab Center this morning, that if we're designing something new, whether it's a patient educational curriculum, a pamphlet, a new video, a PowerPoint education talk, if it's intended for a particular audience, wouldn't it be great to involve that audience? The evolution that we went through in our program of patient education was that 20 years ago, the education was driven by the professional, usually the physician, who would develop a slide set. And we actually, when I started as director, I actually inherited. Does anybody remember the old Kodachrome carousels where you put your slides in and you screw the top on, and then heaven forbid you drop it and all the slides pop out, you madly put them back in? So you remember, like that was the version of education, right? We revolutionized by developing computer versions of slides. I grew up when we actually had to photo them and then send them to the developers, and it was a real crapshoot whether you got a slide or not. So that was the evolution. And then we thought, for patient education materials, all we need to do then is print out the PowerPoint slides. Here you go. Here's everything about heart disease. And we all recognize that's a silly way to try to teach people. And then we said, okay, next evolution is, why don't we take the PowerPoint slide and translate it into some words? written by the professional, recognizing that's not a good way to tell people anything. People don't understand the things that we say. So eventually we got to the idea that if you really want some useful materials, then you should actually work with your patient population or your public population, hear what they want to know, when they want to know it, in what formats, and use the right kind of language. Not so revolutionary, but not really done anywhere, which is really interesting. One of the first steps might be, if you want to know what people don't want to know, then you might develop a tool to figure out what people want to know. And what we found, and this was published in around 2015, 2014, was that no one had actually developed a tool to ask people what they want to know. I guess prior to 2014, we just assumed what people want to know, and we just did it. And that was the state of the art, which is very fascinating. But some very simple things, like if we're developing a good research protocol, we said, yeah, we should go figure out what the audience wants to know. Let's do some focus group. Let's do some surveys. Let's interview people. Let's involve the audience in actually reviewing things. That sounds like a really rational way of developing a product. Test market. People out there that make telephones and eyeglasses and clothing, they know this. You should do kind of an experience with your test market before you actually launch. And in fact, that actually helps. Plain languaging, which is really interesting. And my anecdote here is that we've done work around the world in a whole bunch of different countries, again, 100 different languages in Toronto. Very often through the course of a morning in a clinic, we'll have a translator in our clinic as well because of the different languages that are spoken. So we've gone through great efforts of taking our materials and starting translations of other languages. It's hard, it's painstaking, getting the right vernacular, the appropriate cultural adaptations. Having done all of that, I will say the most difficult translation we have ever done is from English to English. And that's medical English to plain language English. We know that we've done something well if its wording, structure, and design are so clear that the intended readers can easily figure this stuff out. Most often, we don't do this particularly well. And in this intentionally ironic, somewhat tongue-in-cheek sort of treatise on plain language, the author Natalie Ames writes this: higher education customarily encompasses instructional strategies and techniques that promulgate and reward unnecessarily esoteric inclusion of professionally specific articulations and convoluted expressions of language devoid of clarity, which are incomprehensible to those unassociated with said linguistic articulations. Being at the University of Vermont and Medical Center, this probably feels like home to you. Yes, I love this. This is very academic. It's very eloquent. This is a lovely statement. We embrace this. And should we give this to our patients as well? Well, sometimes we think the bigger the words, the smarter we are, and that's what we should say to patients, right? We'll come back to this. This is devoid of, maybe violates some of these plain language best practices. So there are a number of guidances around how one might best do this. This is from the Institute for Healthcare Advancement that would suggest these things that I think are familiar to us because we try to do this in some of our education work with students. Avoid words with 3 or more syllables when possible. Avoid, explain, or teach the meaning of words when they're likely to cause some confusion. Write in an active voice, use first or second person, limit its sentence to less than 15 words, skip nice to know information, use bold or enlarge and chunk information, use large text, don't use italics or caps, leave white space, use numerals on slides, remove clutter, etc. So I think you've all seen this at some point when you're putting your own presentations together. You probably have those principles. But here would be a paragraph that we pulled from somebody's patient education site on atherosclerosis. And this is what we might come up with if we were kind of writing something about atherosclerosis that was meant to educate people. When plaque clogs your arteries, that's called atherosclerosis. Cholesterol, fatty substances, cellular waste products, calcium, fibrin make up these deposits. As the plaque builds up, the walls of the vessels thicken, et cetera, et cetera. So it sounds like not too bad of a paragraph, but you wonder if you can make this better. And a simple way that we might do this is, why don't we take this, streamline it, chunk it out, create some subheadings so it actually looks and sounds and feels better. So this kind of work is actually a domain of experts, plain language experts, where you can actually take this information in a way that people can actually understand it, which is really, really important. We can take some of our medical words and do some simple things like translate them into things that people can understand. Hypertension is high blood pressure, glucose is sugar, angina is chest pain, etc. And these are very important things for us to take. There are resources that we can also turn to that help us in this plain language quest. And I want to talk about a couple of them, in particular the fog, in 1 second. So we could take that paragraph that we reviewed from Natalie Ames deliberately and run it through the Gunning Fog Index on readability, which is actually a fun little exercise. So it scores based upon the number of punctuation marks in the paragraph. And there's only one. There's one period at the end of that sentence. There's 37 words in this paragraph. And of the 37 words, 21 of them have more than 3 syllables. The fog index, which is roughly correlated to like the grade level of this work, is grade 37. Go figure that, right? We could say this stuff in a different way. Like, we shouldn't use big words that are really hard to learn or understand. And we can change the fog index to 4. All right. So we're obviously somewhere in the middle. And when we try to do a plain language version of our own work, we probably do better than grade 37, but we may not get it to the point that it's actually useful and digestible to people. And there's kind of an index of what this sort of looks like. The third thing that we might do is actually deliberately assess health literacy. If we think this is a big issue, then we should probably go measure it, just like our psychologists in the audience would. If we think depression's a big issue, anxiety is a big issue, let's go assess it. Well, health literacy could be a big issue, and maybe we should actually check it out in our people before launching into conversations where we're trying to convey complex concepts with them. And there's toolkits for this. I'm going to pick on one of them just to start through an illustration, that there is something called the newest vital sign. The implication here is that in addition to heart rate and blood pressure being vital signs, health literacy assessment should be a vital sign as well. And here in this tool, what's provided is not something about health necessarily, but a label from an ice cream container. Considering that being able to navigate the information like this is kind of like managing your own health. So if one had a label, and then we start to ask some standardized questions like, in this package of ice cream, there are 4 serving sizes. Each serving size is a quarter of a cup, and there's 4 servings in it, and each serving has 250 calories. Therefore, if you eat the entire container of ice cream, how many calories will you eat? And all of you will say, well, that's a silly question. I can do that, of course, that there's 4 servings in this container, and each serving has 250 calories. That's 1,000 calories. That's easy. But for a person with limited literacy skills to be able to go to that label and decipher where are these things that I need to know, and then I need to do some basic math, that can be a challenge. More. If you eat 60 grams of carbohydrates as a snack, how much ice cream should you have? A problem where now you got to subtract 42 grams of saturated fat you're allowed each day, which includes ice cream. If you take the ice cream away, how many grams of carbohydrate do you eat? So these sorts of mathematical things will test literacy and numeracy. The literacy one is here, the 5th question. Pretend that you're allergic to the following things: penicillin, peanuts, latex gloves, and bee stings. Is this okay? Is this ice cream okay to eat? And you say, well, again, silly question, but it's actually a real life thing for this individual. And you have to figure out, well, I need to go to the ingredient list. And in the ingredient list, there's cream, milk, sugar, water, egg, yolks, brown sugar, milk, fat, peanut oil, sugar, butter, salt, carrageenan, and vanilla extract. So is there anything in that list that matches my list of allergies? And if you figure out, yeah, peanuts and peanut oil that you didn't expect to be in your ice cream, that this is not a good thing for you, go look for something else. So these are basic health literacy things that could be assessed with this tool. Another one that might be incorporated into the clinic environment is this, called a brief tool, where you can just ask 4 questions. How often do you have someone help you read hospital materials? How often do you have problems learning about your medical condition because of difficulty understanding written information? How often do you have a problem understanding what you're told? How confident are you about filling in forms for yourself? and then score it from 1 to 5. And how often have we just given surveys to people and asked them to fill it out? Or please fill out this demographic questionnaire for your clinic appointment. Away you go. Maybe the first question should be, can you fill out the form? Or should we do this in a different way? Might be a friendly kind of question to ask. And if you score less than 12, that will indicate that literacy is probably low, that we need to find a different solution for you to successfully navigate our medical appointment. At the extreme of this, of course, are some really scary stories, like a woman who comes in who couldn't actually read the consent forms, but was told to sign here, here, and here. And she went ahead, had an operation that she didn't know what it was because she couldn't read the form, learns 3 months later that she actually had a hysterectomy. Go figure. Go figure. Check for understanding. And some of the clues that people are having challenges might be things like this. If a person feels frustrated and angry about a treatment that didn't work, the issue might be that they're frustrated and angry. They're difficult people, we label them. Or it might be that there was a challenge in our exchange of information. They actually didn't understand what we were trying to convey, or what the treatment was, or what the expectation was. They just know it didn't get any better. If people show up too much or not at all, then that might be a sign of low health literacy. Again, they're not just angry. Despite reading the same instructions over several visits, the condition still may not be managed. And in my world, they're a really difficult person. They just don't get it, right? If people say, kind of as a side angle, I left my reading glasses at home, I can't read this for you right now, or they bring somebody to help them out, those might be good strategies actually, but just to be aware of that. Observing for nonverbal, that might be important as well. Another story, if I may, the danger of assumptions. So I saw somebody for management of asthma, and one of the treatments for asthma are these kind of inhaler drugs, right? One of the inhaler drugs is called a reliever, or salbutamol, a beta-2 agonist. You take it, it stimulates beta-2 receptors, opens up airways. My friends in respiratory rehab know this very, very well. So that sounds like a good construct, right? So some people living with asthma also have precipitants. It might be environmental things, it might be drug things. For this person, it was things around the home that seemed to trigger asthma episodes, tightening of airways, wheezing, things like dust, dander, cat in the environment. So we have that conversation about environment, give them this prescription, say, you can use this drug whenever your airways are feeling kind of tight. We know that if people are using the drug too much, that's a sign of poor disease control, because ideally you shouldn't need this at all. If your disease is good, you don't need relief, you don't need rescue. That's the other term for this, right? So we're concerned about her. We don't know how she's going to do, how she's going to use the medication. So we invite her back in 2 weeks. There's either 60 or 100 doses in this thing. So we'll send her away. Everything should be fine. 2 weeks later, she comes back and says, I'm feeling okay. Can you show me your medication? And you shake the canister to see how much drug there is. There's no drug left, which says, oh man, I'm really concerned. You say you're feeling well, but your canister is empty. I mean, you've used the squirter 100 times? And she said, yes, I'm feeling very well. We talked about the dust and the dander and the cat. So I sprayed all of them. And I'm feeling perfectly well right now. I thought, wow, interesting. Fun story, but true. Wow. To kind of check in with people, are we getting things right? And that's a problem with us, right? It's not a problem with the person, it's a problem with us. If we can just ask some fundamental questions like, what's going on with you? What is your main issue? And what do you need to do about it? And why is it really important? These good behavioral kinds of questions that folks are into, then I think that's going to be really helpful. And we don't do this often enough. And just remembering this as well, like, is very disheartening, right? That this notion that teach back is really important, because in the usual construct of anything, whether it's this lecture today or a clinical appointment or a research appointment or a teaching session, a person will forget 40 to 80% of the medical information that they hear at their doctor's visit, and of what they hear, half of it's wrong. So the likelihood of success is like 1 out of 4, maybe. The likelihood of failure is 3 out of 4. This is a terrible construct. I don't want to go into this business where the likelihood is that we're going to have really bad things. How do we improve the odds somewhat? Is by using things like Teach Back, where we explain the concept, but then ask the people to repeat it back to us. I'm not challenging you, but I just want to do a check-in to see if I've got this right. If I did my job in helping to convey the information. So just want to check that you can tell me back what we've talked about. Use your own words, and then kind of go over things again if we need to. And then the notion of universal precautions. Now, we're good at universal precautions in the time of COVID and the aftermath of HIV and SARS. We wear gloves, we used to wear masks, we used to do all these good things around universal precautions. But we should also think about this in the health communication thing. And if we go in with the assumption that all patients and caregivers may have difficulty, like that's a good starting point. We don't want to belittle people. We don't want to denigrate what people know, but just make the assumption, because it's a pretty good assumption. 75% of everything we're going to talk about is going to go sideways on us. So why don't we make that our assumption that we're going to have a challenge here? And even people with strong health literacy skills may benefit from a health literacy intervention. Met very, very bright individuals, well educated, where the health part just went off the rails. And here's my next story. True story. I've changed some of the details to protect the innocent. But recently, a patient writes me from Florida saying, wintering down in Florida, which Canadians do. Canadians love to do that. I don't know if folks from Vermont love to do that as well. But going somewhere warm for the winter is a pastime. Sometimes folks, when they go down south, end up developing medical issues. There's lots of clinics for that. So this person develops some urinary issues, goes to a men's health clinic, and get some treatments, and but wants to come back to Canada and get hooked up into a clinic, and wonders if I can kind of facilitate an appointment. I say, great. Send me, if you will, send me copies of your correspondence, any reports, any letters. Send me anything from imaging as well. Sounds reasonable, folks? You're with me? Good. Okay. So the next day I get an email that has letters from the clinic, some blood tests, and a photo of his private parts. I'm thinking, why are you sending me obscene email? I don't know you that well, nor do I want to know you that well. And then I reflect on the conversation. Send me reports, send me blood work, send me imaging. And what I mean by imaging is ultrasound, CT, MRI. He interprets the term imaging. Send me a photo. Wow, this is really interesting. True story. True story. Change the details some, but true story. So making assumptions or not being clear enough about the things that we really intend can lead to bad things happening. This, nobody got harmed, but just I wonder. Having some literacy resources may also be helpful, and there's a number of great sites around the country that will provide you tools, whether you want a literacy assessment or tips on plain language or design. There's really some really great things that we can embrace and incorporate. Okay, I've got a couple minutes, 7 minutes before I use up my allotted didactic time. So we just want to share with you how have we embraced some of this stuff and how might be useful. So some health literacy in action. Again, we made the commitment to evolve from slide decks and carousels to things in PowerPoint and PowerPoint handouts to written materials that the professionals wrote to stuff that people can actually use. And that evolution we put up into a web platform for patients that we called the Health University. And inside the university, there's a couple of colleges. One's called Cardiac College for people with heart disease, Diabetes College for people with diabetes. And some of the important aspects of that is that the materials were built with real purpose, had that user-centered design with inputs from all kinds of people, reviews, information needs assessments, and then setting up some pillars for the program of here's why we are putting up information. Not that we just want to just put up a bunch of pamphlets or a bunch of videos, but there's actually structure to this. And we thought that for people to do well managing their own diseases, that they should understand and treat their diseases. And then for the health behavior part, people should get active and they should eat healthy and they should feel well managing emotions and stress and sleep, ultimately taking control of health so that they know about goal setting, action planning, motivation, confidence, and doing all of those things. And we put that into a web platform that looks like this, where those 5 pillars are in there. There is also a construct of this material in a fun video format. how do people learn? And the answer is people learn in their own way. So some people love to learn by give me the book. So if we're at the university, this is the textbook on how to look after yourself. It's a 250-page manual on heart health, and people can download that or they can get paper. Or you can click through the website if you like to scroll through web pages and interact material in your own non-linear format, and then you can see video and all kinds of things. There's a language control here as well. So when we actually view the guide, it's chunked down into pieces of information that are all color coded. That the blue ones are about treating your heart disease, and the green is about exercise, and the yellow is about nutrition, and purple is about psychosocial health, and the orange is about your own self-management. So it's chunked down into smaller material that people can put on their e-reader, or they can get the paper versions of this and carry them around and mark them up and do all kinds of really good things. And then we also recognize that, again, in Toronto, as well as working with a whole bunch of international partners, that we can do more around the diverse nature of our populations. So we did things like take all of that material and start to translate it, but also like do forward translation, back translation, validation with the populations, making sure that things make sense. Like we did, one of our first translations was in Portuguese for Brazilians. We had stuff in there about how do you cope with cold weather in Canada. Not so relevant. And then when you talk about food in an Indian population who speaks Punjabi, our discussions around fruit and veggies may not be the most appropriate kinds of things. So adapting all that's really important as well. So that was all really kind of fun and interesting work as well. So all these materials are available. There's video things about exercise, about nutrition. There's Ask the Expert series. And during time of COVID, this kind of stuff was really highly utilized. Hundreds of thousands of people looking at this from all over the world. And the plain languaging stuff, I think, was the really critical part of this to make it a viable sort of resource. And I know our colleagues in Vermont are using some of these materials as well, which is really quite gratifying. Okay, so that was kind of our efforts in working on the health literacy kind of pathway and thinking about why that might be important. Okay, so thanks for sitting in. Thanks for attending. Happy to entertain any questions if there might be any. And if you want to chat about any of this stuff or anything, exercise, behavior, heart disease related, happy to connect at any time. All right, thanks. I'll stop there.
Well, questions from the audience, live audience here. Oh, we have one.
Yeah, so I was interested in whether in some of your work you have looked at the role that health literacy plays in patient provider relationships in terms of, does it help increase patients' ability to access patient-centered care, to engage in shared decision-making, or to understand how to advocate for themselves or their family in the health system? And have you guys been able to explore any of kind of how health literacy might be playing a role there in your clinics?
So thank you for that question about health literacy and kind of that provider engagement. So I think the honest answer is no, but sounds like a really great area. One of the domains of health literacy that we do talk about, though, as an intervention, is around kind of improving those communication opportunities, how to advocate for oneself, how to be prepared for an appointment, how to write down your questions, be ready in this kind of format, depending on what the provider format might be as well. So those kinds of survivorship skills are really, really important. But examining more of that dynamic, I think, is an open area for exploration as we start to get more into this. So thanks for that.
Bill, do you want to do a question from the external audience?
Yeah, I don't see any questions from the external audience yet.
We have another here.
Thanks for a great talk. I think we're getting a little echo here. Well, so yeah, that was really informative. Thanks a lot. My question is, so I noticed when you were talking about translating language into more plain language, you didn't once mention sacrificing content or changing the meaning of what you're trying to communicate, which I think is really important. And in our group, we talk a lot about harm reduction and how to communicate that accurately. I wonder if you ever get pushback from people saying changing the language, as you showed us here, sacrifices content. And if you do, how do you respond to that? How do you navigate that where you can translate something to communicate accurately without sacrificing the content?
Yeah, super question. Thank you. So, in the process of English to English translation, plain language, what do you give up along the way? And honestly, so yes, we have had pushback about, you've made this too simple, but not from the patients. It's from the professionals around us who feel like, yeah, you're not telling everything that's really critical in that person's mind. From patients, I think they see there's just way too much stuff you're trying to tell me. I'm not going to absorb most of it. So we might as well hone in on, like, what's the really critical three things that you really want to tell me. So it's even more reductive than we might think. Um, and again, I don't think patients will push back on that. But having said that, there obviously are very kind of well-informed individuals that want more. So there, I think the challenge will be: can we provide materials at another with greater depth? So here's the core stuff, but if you want the extra readings, and it might be an extra reading or extra video, or here's the hour-long session that you can actually watch that we've recorded, that goes into much more depth, exquisite depth about a topic. So having those kinds of options available so that people can tailor the information that they really need, but being reductive in a way and focusing in on the essential things, I think are okay from the patient perspective. I think sometimes we just have to get over ourselves. And we went through this interesting experiment recently, case in point, where we were taking our diabetes college and putting it into a whole new web platform. Excited. So we can make this new, cool, exciting, dynamic. And, we had external people come look at the stuff and said, really great content, but you just got so much of it. We need to redo it. I said, great. We get a team together. The goal is we're going to build the new website. Everything needs to be slicker. Let's focus in on the essentials. The outcome, of course, is there's more material. When we give it back to the professionals, they said, not that we want to eliminate things, we just want to add more. But, oh my God, okay. So we're going to be back into this situation of, let's create the 101 essentials and then stack materials in different ways where people want to learn more, they can do more. Yeah. The other thing that we didn't talk about around essentials was doing some evaluation. And the other part of this whole health literacy experiment that we've been involved with, that others have been involved with, is we can certainly provide education, but it's also good to assess it and actually formally evaluate things. So developing, first of all, a decent assessment tool, psychometrically validating it, deploying it systematically, looking at the information and seeing how that jives with what's happening with individuals. So not the engagement stuff, but around actually health outcomes is things that we've looked at as well. So we can be, we like to say that, quote, this is an evidence-based curriculum, the stuff we've done, because people learn things. We can show you that they learn because we've done standardized assessments. And then the assessments of knowledge gain actually translate to behavior change. And then along the trajectory, it's not just education, but it's other things that happen actually lead to an outcome change, like less hospitalization, less death. And again, so part of the evidence thing is if we have less for the education, we can actually continue to run that whole trajectory and we're okay. But if you want to tweak it, then you should assess what happens. And we've done that over and over in COVID, of course, because we change the models, we adapt because of whatever restrictions are in play, reevaluate what we've done to see if we can still have fidelity with the outcomes that we want to achieve.
Other questions?
Yeah.
Yes, thanks very much. That was really interesting. Again, being from this group, EDM, I always bring it back to the kind of behaviors that we focus on, related to something like smoking in particular. On the individual level with patients you see who smoke, what's your kind of preferred way to communicate the kind of average risk of a certain outcome like disease or mortality that we work with when we're looking at population studies on the individual level? Because it strikes me that you have smokers that know that smoking is harmful, they say, but that doesn't apply to me.
And I had a good chat with your colleague this morning about smoking and communicating information. So I'll say some erroneous things. How's that? Loss aversion and communication of risk percentages and fractions and things like this. I don't think that we would be. I'll give you a good behaviorally theory-driven answer on this. That the plain language version of this would be I'll channel my smoking cessation gurus that work around me, that if you are a smoker, the single most important thing that you can do for your health for the future is to quit smoking. And we want to help with you on the way. That may involve conversation, it might involve medications. You'll probably, if it's the latter, it's not a single short intervention. It's something that we may need to go on for long term. If you smoke less, that's a good thing. If you move to a less harmful thing where you're not burning it, that's a good thing. We're not judging you on that. If you need 2 patches and double dose varenicline, that's okay too. It's more of that as opposed to you've got a 10% chance of dying next year. We tend not to push those scary numbers at people, but rather move into the positive motivation. Here's things that are in your control. And then also, I think the same things that you do. If you're not ready to have this conversation about smoking today, that's quite all right. What would you like to work on? You have a much better answer than that. So I'd love to hear it afterwards.
I have a question. I'm just curious. I think the topic is fascinating for the lecture. Can you characterize, give us a sense of the average health literacy of patients that come through your clinic? Anything say about Toronto or the nation or globally? I'm just curious what you know at that level.
Yeah, thanks, Steve. And I think we recognize it's quite variable depending on the day or the sample that we're taking. But in one of our projects that was led by one of our scientists, Gabriela Ghizzi, we actually undertook kind of knowledge and literacy assessments comparing a Canadian environment and a Brazilian environment. Not surprisingly, folks that live in a large urban center where there's a number of universities, colleges, a public education system, i.e. Toronto, that literacy levels are actually pretty good. Pretty good. Many folks, the majority of folks who have completed high school, many folks have had a college level education. So literacy is quite good compared to more rural populations where there's going to be a significant, measurable, demonstrable difference in what people know in their backgrounds and the materials that they're able to access and digest reasonably. And again, it's going to vary around the country. The other observations, though, anecdotally, again, sometimes there is a marked disconnect between the education one has and the kinds of things that come up. The stories that I shared were a couple from well-informed individuals. I've got other ones. A high school principal says, we review their diabetes profile and they tell me that their average A1C is 0.10. I think everyone knows in the audience that that's pretty darn high. And he'll say to me, well, it's 0.10. I have diabetes. So that's what I'm supposed to have. I thought, wow, okay, that's an interesting kind of reflection as someone who knows numbers, who understands disease, but there's still this disconnect. So we find pockets where it's a challenge. The other thing I'll say is that sometimes literacy is hard to move, right? People have grown their lives with a certain kind of construct, and we can work on elements of knowledge, but we may not change that much around literacy. But it's important to recognize and then develop the tools where we can actually convey information in a meaningful way that will match their literacy levels.
So one I had was, as you've been implementing this change with health literacy, are there any unexpected outcomes or anecdotal things that have come about as a result of moving in that direction to where you didn't necessarily think it might be an outcome, or anecdotal places where there's more engagement or people are coming in more for services, or they see a website and they can understand the material better, which gives them a better sort of foundational knowledge as they're coming in for services? Have you noticed anything along those lines or seen anything cool?
Well, thank you. And just wondering, is there some other measurable impact here? Um, as we've been on this journey over the last 10 years, I think much of it has been quite positive. This is one of these pieces of passion work, right? That many of us get involved with, which has been exciting. It's been very entrepreneurial as you move along. That I think you'll recognize that to do this kind of work, that someone's got to fund it, but no one's really that interested in funding it, frankly. But it has importance, I think, because it's having a real impact on people. What have we learned? Again, sometimes this disconnect between what professionals think you should know versus what patients want to know, and like who is the real expert in the room is maybe not us, but it's the people that are consuming the material. So that's a hard realization for us who have been told that they're expert, especially for physicians who say, yeah, we're at the top of the pyramid. Everything we say, oh, that's gospel. This is the only important thing. So that's an important realization. Trying to engage with people in a more holistic way has been really useful and important. And in our world of rehab prevention, or your world in behavioral psychology, you work extremely well. You get to know the folks really, really well. And I think it's the more we know, the more we need to know more, right? So we can uncover, like, what's your mood, what's your cognitive abilities, who's at home, and what's your behaviors. Now we're uncovering, like, what's your educational construct, how do you actually like to learn, when's the last time you asked that kind of question, what's your personality. Like, the more we learn, and for those of you who go through kind of leadership training, you do all these things, right? Usually day one of leadership training is either doing like a Myers-Briggs or something else, where you just peel the layers back about yourself. So I think that's been an interesting learning about how we might engage more meaningfully. Again, I think it's been gratifying to say that this is not the only thing, obviously, and all the other work that's done around medications and procedures and interventions and exercise and psychology is really critically important. But here's one more thing that we should put into the mix. And chatting with Patrick Savage this morning, Patrick, if you're online, this is your statement to say, we built some fundamentals of what we think should be in a standardized guideline for patient management. And maybe one more thing that we might add in the next construct is this notion of literacy education, helping people learn more about themselves. Because what we always tell people is that you're with us for a short period of time, whether it's a single visit, 12 weeks, 16 weeks, but you're with yourself the majority of the time. In the life of people with diabetes, like, who's the expert? The endocrinologist, the diabetes educator? No, it's the person managing their own condition 99% of their life. Who has to be the expert? It's the individual, not us. So that's what this journey has been about. And it's good because it makes us give up this kind of professional top-down sort of thing. So that's been my personal reflection on this. I'm sharing way too much, so I apologize for that. It's like therapy, being in front of a bunch of psychologists.
Thanks for your talk. So one kind of reflection that I had on this is that your model for health literacy very much is kind of in the context of, like, the individual patient is the person who needs to have the health literacy to be able to manage their condition, because they're the person who's with them every single day. But I'm also wondering about, like, situation, like, how you conceptualize, like, the family dynamic, because for a lot of people, they might not be, like, the primary decision maker when it comes to their healthcare, and they might be, like, relying on, like, their children, if they're, like, not a native English speaker and their children are. How do you conceptualize health literacy education for those types of situations?
Yeah, fabulous. Thanks for the question. And again, I probably won't give you the right theory or the optimal theory kind of thing. I'll give you the pragmatic kind of view on that. And absolutely, like, health, although I've emphasized that the person needs to be the self-manager, I think you're right that for many people, it's the family that needs to be a self-manager, or a group manager, that behaviors like smoking, like food, like physical activity run in families as opposed to just that individual. And sometimes a targeted intervention against just one individual may not be that successful. Think of the smoking folks in the room. If you get one person to stop smoking, but everyone else is, then you've maybe moved the needle just a tiny bit, but you really need everybody to stop smoking. Same with food patterns or activity patterns. And so you're quite right that often, or not uncommonly, the interventions around education need to involve more than the person. You know, I apologize for being a little bit stereotypical here, but sometimes with couples, that food, shopping, and prep and cooking falls to one of the partners rather than the other. And having the right person at the table, so to speak, will allow this to actually work properly. So things like nutrition education or cooking demonstrations need to involve both. Having a parent get active, the solution there might be to teach the children to kind of emphasize the importance of being active and taking the parent out. Language translations, people with cognitive impairments, it has to be a family game for sure. So involving more in the relevant kinds of education, moving the dial on total family literacy, I think is great. We haven't gone down the road of assessing that though, which I think is very interesting kind of area of research.
Thank you.
Thanks.
I have another one for you, Paul. I was curious, your clinic is devoting time to this not only because it's a research interest, but because it promotes health in your patients and whatnot. So I was curious on your thoughts about integrating health literacy curricula in primary education or efforts to educate the population more generally as a health prevention and promotion effort.
Yeah, what a fabulous idea of, should some of these topics actually make it into school or somewhere else? And
exactly.
I think that that's so important. And I guess we've struggled back and forth about what goes into school education, and certainly in the United States you have, in Canada we have as well. My physical activity colleagues will bemoan the removal of things like physical education in school, or sex ed or health ed as important topics. And I'll be very careful with not going political on anything about what goes in or not in to a curriculum. I think many folks will say the more you learn about yourself, the better you're going to be. And what could be more important to learn as a life skill than how to look after yourself? Agree completely. How can we advocate for that and get that integrated? I think it's so important. On the adult side, I'm always struck by experiments that sound new and exciting. One of my colleagues in Toronto developed something called the mini medical school, where adults were invited to come and learn about their bodies and diseases. And it was immensely popular for a small segment of the population. However, usually people with very high levels of education, like university alumni, they want just to do the next level things. So it may not address the issue of people who really need to learn more about themselves not having access to those kinds of things. But great, I think we should look at those kinds of public health interventions.
All right, so we're out of time. Thanks very much for
All
a
right,
wonderful
super.
lecture and Q&A session.
Thank you. Thank you very much.